First of all, I wanted to thank the organisers for inviting me to present some of our data. My laboratory is located at the Mater Research Institute at the University of Queensland, and we're very much a basic discovery / translational cancer research laboratory. We have a big focus on developing new theranostics at the moment, and the most advanced of our discoveries relates to this protein called CDCP1, which I've represented here, and a monoclonal antibody called 10D7. So these will be the two major topics of the presentation, but I did want to highlight that we have 4 or 5 other receptor antibody pairs that we're interested in pursuing for a range of different cancers. I wanted to give you one slide worth of background before telling you about the topics that I'll talk about for the majority of the presentation. And this background relates to the fact that about 2 years ago we received about $2 million in funding from the Medical Research Future Fund to conduct a phase 1 PET imaging trial in 15 women who have recurrent ovarian cancer. And the target that we're going after is this receptor CDCP1 using a human mouse chimeric form of the 10D7 antibody, which we've labelled sequentially with desferoxamine as the cage and zirconium-89 as the beta-emitting radionuclide. So we're currently manufacturing that to clinical grade. Hopefully towards the middle of next year we'll be ready to infuse our first patients. They'll have PET scans 4 hours later and 1, 2 and probably 4 or 5 days later. And then what we're hoping to see, images like this. Now this isn't one of the patients, it isn't data that we've generated from any patients, it's data that I've taken from somewhere else. But it highlights nicely what we're looking for. So what we're hoping to see is that our agent accumulates very strongly in patient tumours, and any signal that's coming from normal organs is at much lower level. And if we achieve that, it's going to be a proof of principle that CDCP1 is a valid target for ovarian cancer and potentially for the other cancers that express CDCP1. So if we demonstrate that this is the case, we're very interested to then swap in therapeutic payloads, either higher energy radionuclides like lutetium-177 or cytotoxic payloads like monomethyl auristatin, which is a cytotoxic drug. So with that in mind, what I'm going to talk about for the rest of the presentation is really the preclinical and discovery research that we and others have conducted, demonstrating the important features of the biology of CDCP1 that make it a good target for delivery of imaging and cytotoxic payloads, so make it a good theranostic target. So the first set of experiments I want to tell you about are those that demonstrate why CDCP1 is important in cancer, demonstrating its elevated expression in many cancers and also its cell surface location. I'll focus then on its structural features, including its cell surface location, and in particular, what happens to the receptor when the antibody binds to it. So this is important biology to understand in terms of understanding the potential utility of antibodies that bind to CDCP1 and the sorts of ways that they can be used. I'll then show you a couple of pieces of preclinical data that we've generated. We've generated and published a lot of preclinical data where we've attached various payloads to the anti-CDCP1 antibodies, including beta-emitting radionuclides, payloads for PET imaging, and cytotoxic payloads for cancer treatment. And a lot of this work is being conducted with patient-derived xenograft models of ovarian cancer and pancreatic cancer. And it's that work that really has justified us receiving the funding from the MRFF to take the work through into a clinical trial. Then towards the end, I'll spend a little bit of time talking about what we're doing to generate an optimized monoclonal or human mouse chimeric antibody for manufacture and validation to be used in the trial. So the first piece of evidence about why CDCP1 is important in cancer comes from a lot of immunohistochemical studies of patient tumours. Now we've published 3 papers in this area. on high-grade serous ovarian cancer, ovarian clear cell carcinoma, and pancreatic ductal adenocarcinoma. So this is immunohistochemical analysis of reasonably sized patient cohorts, 222 for the pancreas study, 198 for the clear cell ovarian cancer, and 292 for the high-grade serous ovarian cancer, and other. So we've shown that CDCP1 expression is elevated, markedly elevated in each of these different tumour types. And other groups around the world have shown similar data for other cancers, including metastatic triple-negative breast cancer, metastatic HER2-positive breast cancers, lung cancers, colorectal cancers, kidney cancers, some prostate cancer cohorts, liver cancer, and also various leukemias. And the consistent story coming out of this is that CDCP1 is not expressed in the normal tissues, the normal organs, but is markedly upregulated in most of the tumours that are analysed. So in our cohorts, somewhere between 75 and 90% of patient tumours demonstrate markedly elevated expression of the CDCP1 receptor. Interestingly, elevated expression in each case corresponds with much poorer outcomes for the patient. Another important finding from the immunohistochemistry is that it confirms that CDCP1 is located on the cell surface in patient tumours, and that's apparent from the immunohistochemistry represented here. So the brown signal from these tissue specimens is the CDCP1 signal. And what you can probably appreciate from this blown up image here on the right hand side is that most of the signal is located around the periphery of the cell. So this confirms to us that in the malignant cells, CDCP1 is present on the cell surface, and at that location it will be amenable to be targeted by antibodies or peptides which bind with high affinity to the receptor and be useful as a tool. The antibodies will be useful as a tool to deliver cytotoxic payloads for treatment and beta-emitting radionuclides for imaging and detection. We've shown that CDCP1 is not expressed in normal ovary. We've published that, and we also have extensive unpublished immunohistochemical data of over 40 normal tissues, which show that CDCP1 has very restricted expression pattern in normal tissues, and which confirm to us that it is a valid target to go after, and any toxicities of targeting CDCP1 because of off-tumour effects should be manageable. At least that's our prediction at this stage. Other features that make CDCP1 important as a theranostic target relate to its structure. So on the cell surface, there's 660 of the 830 odd residues of the protein are located extracellularly, so there's plenty of region for antibodies or peptides to bind to the receptor. We and others have shown that CDCP1 does undergo proteolytic cleavage in some settings, and we've shown that this fragment here, the amino-terminal fragment, can be shed from the cell surface and can be detected in the blood of colorectal cancer patients. But just over the last 2 years, we and others have shown that this fragment, in fact, remains predominantly tethered to the cell surface. And this is important because certainly our monoclonal antibodies 10D7 and 41-2 bind to this region. So it's important that we've demonstrated that it remains mainly tethered to the cell surface where it can be targeted by these antibodies. Another important feature of the antibodies is that they do bind very, very strongly to the receptor. So this is, in this box here, is affinity data. It shows that 10D7 binds with affinity of 0.44 nanomolar to the receptor, whereas 41-2 binds with 1.2 nanomolar affinity to the receptor. So the lower the number, the stronger the binding of the antibody to the receptor. And these numbers are really impressive. Another important feature of the biology of the receptor is what happens to it when antibodies bind. And this is some really cool preclinical imaging data. It's real-time confocal microscopy data, where what we've done is we've generated a form of CDCP1 which is tagged with green fluorescent protein, and we've incubated the cells that express this protein with 10D7, which is linked to it, a purple fluorescing dye. Now, when the purple fluorescing dye on the antibody comes into close contact with the green fluorescence on the receptor, that purple and green overlay to become white. And that's what you're going to see in this real-time video. So this is a resting cell before we've introduced the antibody, and what you can see is that CDCP1 is located on the cell surface. There is some accentuation of signal here at these membrane ruffles, but in other parts of the cell, the protein is diffusely located. There's not many regions that are showing concentrated expression of CDCP1. Now you'll notice that this changes very, very rapidly when we introduce the purple fluorescing antibody onto the cells. You'll see an initial flash of purple as the fluorescence comes through. Then as the antibody binds to the receptor and purple overlays green and you get white, you see a coalescing or a coming together of the receptors and then a rapid internalization. So I'll show that now. The purple flash, then the green and the purple come together and you get these white punctate structures forming. And within 30 seconds to 1 minute, we start to see internalization of the antibody receptor complex. And this is really exciting for us because it confirms that, that an antibody that binds to this receptor can deliver its payload inside malignant cells. And this can be really important when you're going after a theranostic target for treatment. Generally, for cytotoxic payloads, you want the cytotoxin to be taken inside the cell because it works much more effectively in killing the cells when it's located intracellularly. So that's really exciting cell biology data. Now I want to take you through some of our preclinical imaging and treatment data in mice. But before I do that, I wanted to introduce the theranostic concept by looking at some prostate cancer data that was published by Michael Hoffman and his team at the Peter MacCallum a few years ago in 8 prostate cancer patients. And in this particular series, they're imaging with the PSMA ligand to which they've attached an imaging radionuclide payload. The ligand binds to the active site cleft of PSMA, which PSMA is also known as glutamate carboxypeptidase 2, so it has a catalytic cleft into which the peptide binds with very high affinity. The initial PET scans show a very high tumour burden in these mice, false coloured as red. Each of these patients then underwent 3 to 4 rounds of treatment where the PSMA peptide was linked with therapeutic radionuclide lutetium-177. So, and then the imaging was repeated with the low energy beta emitting radionuclide for imaging, and you can see that the tumour burden in each of these patients is substantially reduced, if not completely eliminated, at that imaging round. So this is very exciting, and this is the theranostic paradigm that we'd like to achieve in the ovarian cancer and pancreatic cancer patients, and that's what we're working towards. So just comparing and contrasting our 10D7 agent with the PSMA ligand. First of all, the CDCP1 receptor, similar to the PSMA receptor, most of the protein is located extracellularly, so there's plenty of it for antibodies and peptides to bind onto. Our antibody has very similar affinity to the PSMA ligand, so PSMA ligand has 0.37 nanomolar affinity and our antibody has 0.44 nanomolar. And our antibody induces internalization of 100% of the receptors between 3 and 8 hours, whereas the PSMA receptor ligand induces 75% internalization of the receptor after 3 hours. We acknowledge that peptides are much easier to manufacture and to probably implement clinically as a theranostic agent, so we are actively pursuing development of peptides which bind with high affinity to CDCP1, but that work isn't ready for discussion at this stage. So now I'm going to show you in the next couple of slides some PET-CT imaging data and also some treatment data in our mouse models. The first set of data is with 10D7 labelled with zirconium-89 for PET imaging. This first image is of a mouse carrying patient-derived xenograft of ovarian cancer, and you can see the PET scan picks up 5 distinct tumour nodules in this model. So the model is quite a good mimic of advanced disease in patients. what we're interested in is how sensitive our agent is to detect small volume tumour burden or low tumour burden. So in this particular imaging experiment, we do the imaging before the tumours are actually observable to the naked eye. And so after we did the imaging, we opened the mouse up and we couldn't actually find where the tumours were because they were so small. We get similarly impressive data from our pancreas cancer model. Here we inject the patient cells into the pancreas of the mice. We let the tumours develop for a week or so they're detectable, but you can't, or by PET, but you can't actually see them by the naked eye. You have to do anti-human immunohistochemistry to pick them up. So here you can see nice defined tumour burden in the pancreas of the mouse. Now I'm going to switch across to some efficacy experiments in terms of treatment. In these experiments, we predominantly use a cytotoxic drug as the payload, monomethyl auristatin, because it is easier than radioactivity for us to handle in the lab. In this particular experiment, it's a intraperitoneal ovarian cancer model. Here we've labelled the cells with luciferase, which gives off a signal which can be detected using a bioluminescence imaging system. And we've treated groups of mice, six mice in each group, with either vehicle, so that's the green line, naked monomethyl auristatin, which is the blue line, naked 10D7 antibody, which is the red line, or the black line, which is 10D7 linked with monomethyl auristatin. And what you can see is after a single treatment, so this is data from a single treatment, that the 10D7 MMAE causes a significant reduction in tumour burden. It does start to grow back, but remember this is from a single treatment. We also did a survival analysis. This is the Kaplan-Meier curve, and what it shows is that the single treatment with the 10D7 MMAE increased survival by 20 days in this model. And with these models, we only start treatment when the mice tumour burden is quite large, approaching 1 centimetre in total, 1 centimetre cubed in total tumour burden. So the data is really quite impressive. We don't see that with other agents, treatment agents that we've used. So that preclinical data was what we used to justify getting the MRFF support that we did. And we've generated the human mouse chimeric protein, which I've said, and we have performed lots of different PET-CT imaging with the chimeric protein. This is data from a small volume pancreas cancer that's growing subcutaneously, and you can see that it does pick up the signal quite robustly. Now we've got an eye to the future, so what we've done is we've also generated 4 other forms of the chimeric protein, and these other forms we're interested in increasing the stability and the manufacturability of the chimeric antibody, and also eliminating immune system mediated responses. And so we've now got 5 different forms of the chimeric protein, the chimeric 10D7 antibody. And the first thing we've shown is that in introducing these mutations which improve manufacturability and reduce immune-mediated responses, it hasn't impacted the affinity of the antibody for the receptor, but it has reduced or eliminated cell-mediated killing, as represented in this graph here. It's almost down to 0 with these 4 mutants. I don't have time to show you the data, but we have similar data from complement-dependent killing. So we can be confident that our mutant antibodies aren't going to induce adverse effects in patients by activating the patient's immune system. But what they do, they are even better than the parental chimeric antibody at improving survival. So comparing no treatment, the black line here, with variant 2, the green, and variant 4, the blue, survival is improved from 35 to 40 days up to 75 to 80 days. So a really significant improvement in survival. So we've selected variant 2 to take forward into manufacture for use in patients. So just briefly, in summary, what I've shown you is that CDCP1 is important in cancer. Its structural features support that it's a good theranostic target. It's expressed in patient tumours. It demonstrates that it's a good theranostic target. And I've shown you some preclinical data in patient-derived mouse models that support that. And we're now moving on to manufacturability. So finally, I just want to thank the people who did the work, the wonderful people in my lab, our collaborators at UQA, IBN, Centre for Advanced Imaging, Chris Lurek's team and Trent Munro's team, CSIRO team, Marina Pajic at the Garvan, our wonderful imaging team, preclinical imaging team at TRI, our clinical collaborators at MARA, the Royal and the PA, and Paul Thomas, who's been a fantastic and an ongoing fantastic nuclear medicine collaborator. So thank you.